Thank you so much. It's really quite a difficult task to fill in, the last session. And especially that the last session was supposed to be as a workshop shared with my colleague Valentina Christakeva from Bulgaria, also to share her experiences and her practices in Bulgaria with regards to the implementation of the Convention on the Rights of People with Disabilities in mental health area. So first of all, I am the last. Secondly, I am alone, but not alone, because my colleague from Ministry of Healthcare will join me, and we will present just, the one country case, Lithuanian case. Probably not the best one, but actually with a very good perspectives for effectively implementing CRPD in the mental health area. Can I use this? So thank you, Rob, for introducing me. And as you see from the first of my slide, I will be speaking about the CRPD, its practical implementation in mental health. Again, I will be repeating a bit because I will be speaking also about the WHO Quality Rights Toolkit, and as a tool, as a measure in Lithuania to be implemented in mental health area, and also about the legal capacity reform. So actually, when I was sitting and listening throughout those days in the conference, I was so much thrilled to hear so much about human rights-based approach, about the CRPD, and actually was very happy because, first of all, as a lawyer, I thought that maybe it's only my small bubble that is being related to CRPD and the convention and its implementation and human rights-based approach, but it seems that there are a lot of shared practices and very much international intentions to implement the CRPD effectively, and especially from the yesterday's and today's talking about and seeing this as a comprehensive rethinking of mental health is very much promising. So I think I will not need to very much repeat that the human rights is in general based on dignity of human beings, and that in general we as human beings are allowed, and it's not a privilege, it's not a gift, but we are just have basic rights simply because we are humans, and this is already for the 70 more years that universal human rights declarations are speaking about. But when we come to the people with disabilities, of course, it was a very much historical history of a lot of discrimination and inequalities that people with disabilities faced, and discrimination that actually was existing and still existing, as we see both in the community but also in the mental health, social care, education, and all other areas. So specific human rights instrument for persons with disabilities was very much needed, and established universal minimum standards that should be applied to every person with disabilities. So first of all, the CRPD was adopted by the General Assembly of UN in 2006, and since then it started the history of changing the perspective, changing the attitudes, and changing the practices in all the areas. So it adopts a broad categorization of persons with disabilities and reaffirms that all persons with all types of disabilities must enjoy human rights and fundamental freedoms, and again introduces a new disability concept approach from the medical one to social and human rights-based approach, and sees disability as an interaction between environment, social, and personal factors. So it's, again, not only diagnosis, impairments, or situation that the person is in all those factors are very much interdependent and affect the person's well-being and human rights base. So the CRPD has 50 articles. Article 1 to 4 describes basic principles, and those are very much based on dignity, equality, freedom, liberty, inclusion of people with disabilities in all the areas of lives. And article from 5 to 30 are actually rights articles. So we have the articles on individual rights that that describe all the human rights. Actually, no new rights were introduced by the CRPD, but the same rights, existing rights that were still from the, as I said, Universal Declaration of Human Rights. And it very much affects a huge population. It's up to 10% of world's population that actually are or are having disabilities or are related with the disabilities in one another aspect. So it's really a huge population that we speak about when we speak about the human rights of persons with disabilities. WHO Quality Rights Initiative. It was very much introduced already throughout those 2 days, but why I'm speaking about this, because actually it took the WHO took the initiative to refer those CRPD human rights to persons with disabilities into some very concrete tools and guidelines for introducing the human rights-based approach in mental health. So with the overall goal of improving access to good quality mental health and social services and promotion of human rights of people with mental health conditions, psychosocial, intellectual, and cognitive conditions and disabilities, it actually had the overall goal of, first of all, building capacity of the disability community and organizations themselves to advocate and influence the policy making. Then, of course, building capacity of the mental health care professionals to change the attitudes, to change the practices. And with those building capacity, actually trying to improve the quality and human rights conditions in mental health care and social services by improving services, by creating community-based services and recovery-oriented services. So it's also very much aims at reforming national policies and legislation in line with the CRPD. So really, from the point of view of the human rights approach and its implementation, I think WHO quality rights instruments and this initiative in overall is very much, relevant and having its really global purpose. So, first of all, the Quality Rights Toolkit was introduced as an kind of assessment toolkit to promote quality human rights and recovery in mental health by, first of all, assessing the institutions, different kind of institutions of mental health care and social care, health care, in order to really to assess and to rate the human rights conditions and quality of services in those institutions. And it also provided very concrete tools for interviewing, documenting various human rights violations existing in those institutions, and then not to be the whole purpose of only assessing, but also encouraging facilities to develop and put into practice the improvement plans based on the recommendations and findings of those assessments. So actually, this was the starting point was in 2014 when the WHO started discussing and creating this Quality Rights Toolkit. Of course, since 2014, there were a lot of initiatives, later initiatives taken by WHO, but what are the main features of this quality rights toolkit is that it's purely based on the human rights, on the convention itself, and on the themes and standards and criteria that the convention brings about. But it was introduced already, but I will come shortly about the topics and themes and articles that the tool is based on. And it's also designed for using in flexible range of mental health outpatient and inpatient facilities. So the toolkit, assessment toolkit, and later on improvement plans based toolkits can be used for both mental health outpatient facilities, day treatment facilities, psychiatric inpatients units, hospitals, rehabilitation centers, and residential social care homes. So this is really a broad spectrum of various institutions that can be assessed by this toolkit, and the toolkit is also very much used for developing also and including the service users perspective. Both the toolkit itself was developed with inclusion of the service users, but also it is very much facilitated that in all the assessment teams there would be the service users' perspective included. So afterwards, really WHO developed a lot of capacity building tools, trainings, both core modules on different topics such as in general human rights, mental health related, relationship between mental health and human rights, etc. And also specialized models that you can find very easily on the WHO's website on the Quality Rights Initiative. And also, unfortunately, we cannot maybe look those videos that are provided here as links, but WHO also provided and developed a lot of video evidences, testimonies from different countries that started to use this quality rights toolkit for improving the services, transforming services, and promoting human rights. As you can see, it's also the toolkit itself, the paper version, the document developed for transforming these services, but also the videos and testimonies showing how really the toolkit itself, the usage of the toolkit, have impacted the quality of the services and approaches for providing services in those institutions. 5 assessment teams are the basic for within the assessment toolkit, and it's, as you can see from the slide, it's very much related to very concrete CRPD articles, which are probably the most important. Again, I'm not saying that one human rights is more important than another, but those are specifically related and important with regards to mental health area and with regards to the dignified and human rights-based approach in providing mental health and social care services. So the right to adequate standard of living, the right to enjoyment of highest attainable standard of physical and mental health, the right to exercise legal capacity and to personal liberty and the security of person, freedom from torture and cruel, inhuman and degrading treatment, and the right to live independently and be included in the community. Those are the main themes that are used in the Quality Rights Toolkit as standards, and here are also explanation how the toolkit and assessment is being done. So each and every theme is corresponds first of all to human rights, and then is divided or differentiated into specific standards and criteria, and the assessment team using the Quality Rights Toolkit is determined really to assess all those criteria and standards while going to the any institution or facility being assessed. So again, from the point of view of the WHO's perspective and what it had done also with regards to the European region, it was a big project being launched on the European level, Euro project on adults with psychosocial and intellectual disabilities living in institutions in the European region, because again, as mentioned, there were quite a lot of reports and the violations being reported in those institutions, and because it is really highly marginalized and vulnerable groups that live usually in the isolated facilities in the European region, and this really project wanted to address, first of all, to address the gap in knowledge about those institutions and what is happening there from the point of view of human rights, and then really to see how the, it was not specifically pointing and blaming some European countries for not following the human rights, but basically wanted to really to see the basic standards being provided in those European institutions, and then what can be done further. So the report that is being provided also here, the mental health, human rights and standards of care, assessment of the quality of institutional care, has been published in 2019, just before the COVID burst out, and I think this is really very important document to really see the trends in European mental health area. So now I really move to very essence of this presentation, Lithuanian case in implementing the CRPD in practice. And what I'm going to talk about, or to focus mostly about, is really how the legal capacity reform started and where was proceeded with regards to the CRPD-based compliance and standards, and also to talk about the Quality Rights Initiative that actually has started and will be continuous in the current years, upcoming years, also for the improving the services in mental health care and social care. So, as you can see, also there were some other reforms being initiated because or in parallel with the CRPD ratification in Lithuania. But those reforms, like the institutionalization process or mental health legislation reform, I will not focus so much, but they are ongoing, and it's also, as mentioned, it is very much related to the CRPD compliant practices and improvements. So Lithuania is, as you know, quite a small country, 2.8 million, and persons with disabilities, it's 230,000 people with disabilities receiving disability kind of benefits or pensions. So this is how we calculate the disability population. It's on average is the same 8–9% of the population. So it actually it's consistent to the European or worldwide composition of people with disabilities population. And there are not so many statistical data about specific group of people with disabilities, because quite some gaps in the statistics they exist in Lithuania, but we can calculate or count up to 30,000 persons with psychosocial and intellectual disabilities in Lithuania. But the figures for the social care institutions are very exact. And they are not very much decreasing, well, decreasing a lot, but both maybe 5 years ago, the same as now, it's around 6,000 people living in social care homes. And and also up to 200 people waiting in the list to enter the social care homes. So as Dainius Pūras has actually also mentioned today, there is a constant filling in or self-filling the system from the psychiatric or mental health system to the social care homes. Those are the facts, the figures, and we cannot argue them, so we can only try and see how those figures could be changed if community-based services were much more developed, if another alternatives could be supported and introduced in Lithuania. So. In 2020, also the figures are relative, but there is always around 6,000–7,000 of persons declared as incapable or partially incapable in Lithuania. This means that again, those people are considered to be not. From the legal point of view, not the legal persons. I mean, they are substituted by the guardians, and all the decisions are taken by them or in the interest of them, but by others. So those are the figures that I wanted to mention before starting again the kind of reform or introducing to those cases in Lithuania that I want to speak about. I myself, I am coming also from the NGO sector, so I'm a president of Lithuanian Disability Forum, which is an independent umbrella organization and representing rights of people with disabilities on the national level. Why I am speaking about this? Because I would say that this organization, it happens also to exist also 20 years already. Actually, it is the main one which tries to advocate, very strongly advocate for the CRPD since its ratification in Lithuania in 2010, and tries to really secure equal rights of people with disabilities by implementing provisions of the convention, by human rights monitoring, by active participation in the policy forming, implementation and monitoring of the policy, as well as awareness raising about the disability as a human rights issue and informing society and the persons with disabilities themselves about their human rights and about the changes needed. The picture that I'm showing is also our alternative report that we prepared and sent to Geneva, to the UN Committee on the Rights of People with Disabilities, when the review of Lithuania was in 2016 by the committee. And this was quite a crucial moment for us to really, first of all, monitor the real implementation of the convention, various rights of convention in Lithuania, but also to start very clear the advocacy, so advocacy on different rights, how those should be implemented more effectively and more continuously with regards to the CRPD standards. So this alternative report gave us, first of all, the status quo, the kind of assessment of status quo where we are with regards to the CRPD standards implementation, and also the advocacy for the changes. So this alternative report, of course, mentioned a lot also about the rights of people with psychosocial disabilities, both in the mental health area as well as social care area and from the legal perspective. So the legal capacity reform in Lithuania, it has actually it is the civil code in Lithuania was revised in 2000, but some of the legal provisions actually very much related to the legal incapacity still existed from the Soviet Civil Code. So from 1964, we had the provisions, even in the revised 2000 Civil Code, we had the provisions on legal incapacity from the Soviet times. And of course, the ratification of the convention very much initiated various debates and discussions about Article 12, how we are compliant, not compliant, how we supposed to implement effectively the Article 12 in Lithuania. There were also some strategic court cases that also initiated the more discussions and advocacy base for the for changes in the legal capacity area. So the decision in 2012, DD versus Lithuania indicating that legal regulations on legal incapacity violates European Convention on Human Rights and that those should be changed. So all of those monitoring and assessment from the other international mechanisms and bodies also very much influenced the changes or the advocacies in the legal capacity reform. Of course, NGO advocacy was also very much played a very important role, because we as Lithuanian Disability Forum, as well as Mental Health Perspectives organization, which is led by Karilė Levickaitė and working on the mental health area and issues, has been very much also promoting and seeking for the legal capacity reform in Lithuania. So those are two kind of reports we produced on problems of incapacity in the context of European Union values, as well as good practices examples in empowering people with disabilities, providing them supported decision-making. So conclusions from the analysis of Lithuanian legal guardianship system showed that the legal capacity provisions before the reform were, very black and white, bad with regards to Article 12 implementation, because it was usually legal incapacity and plenary guardianship was initiated only for persons with psychosocial disabilities, and for the termless duration, people with disabilities under guardianship lost all of their rights. It didn't provide any alternatives to the incapacity, and only guardianship measures that were actually disproportionate. They were also not very much tailored to the person's circumstances. And so all those assessments led to really discussion about the legal reform. Legal reform happened in 2015, starting into force or coming into force since January 1, 2016. It was actually, to be honest, the biggest legal reform of civil code since 2000 that I was mentioning, that the civil code was in place. And still, unfortunately, those restrictions or those laws provide for restrictions or denial of legal capacity of persons with psychosocial disabilities. Why? I will try to show you. Even the key principles of the legal capacity reform were very much positive and very much CRPD tailored and following the CRPD. So person's capacity must be restricted to the minimum, and the person capacity restriction should be the last resort, and the goal should be really to provide alternatives to the person and to support him in the capacity, in the legal capacity realization. But unfortunately, there were quite a lot of discussions from the both legal point of view, but also from the society's point of view. Both lawyers, psychiatrists were kind of very reluctant to the huge jump from from total legal incapacitation to total legal capacitation. So this is. This was kind of, I would say, half step forward, because we introduced in the civil code two alternatives for the legal incapacity. So assistance in decision-making agreements were introduced, but those are quite restricted also in the format, because those should be subject to notary certification, and the notaries are not very much in favor of certifying those. Also, because of the, again, unawareness or lack of information for people with disabilities themselves, they are not very much used in practice. Also, there is another alternative as advanced directives, which I was very much following today's presentation from Germany. Unfortunately, although we introduced advanced directives in the civil code, but those are very limited in the, first of all, in the, again, format, because those should be, again, certified by the notary and define the matters, how should different matters regarding implementation of persons' property or not property rights should be dealt with, but only in case of he is restricted with his capacity. So first of all, the person should be restricted in his capacity, and only then advanced directives are coming into force. So those are quite disadvantages and gaps in those two alternative institutes that were introduced in civil code. Also, we kind of, again, moved a half step forward with the legal capacity regulation, because the restricted capacity in certain areas was introduced as also a half step, or as a facilitation of person to be at least capable, or at least taking decision in some of the actions and controlling some of his or her decisions because of the limited capacity to understand his behavior or to, in general, understand the situation. So those are still very I would say arguable discussion that was going on, as well as incapacity in certain areas was introduced. And that the court or judge should really assess, very individually assess, which fields or which very areas of life the person cannot take control of his decisions or cannot understand fully, and then only in those cases or in those areas the person should be declared is incapable. And also, so at least some individual assessment is provided or is in place, and the judge should really take very good care of those selecting of those areas. And another new development that was introduced was the commission of the review of the incapable person's condition, which actually exists on the municipal level and without the court. Every year it should review the legal incapacitation cases, which means that comparing to the previous provisions, we again moved forward, because previously the legal incapacitation was termless, and now at least this commission can review each individual case on the basis of probable changes in the person's legal and situation and his condition, and then in general seeing maybe there were some changes, or there could be some changes in the legal incapacitation procedure. Looking from the perspectives and good developments, we in Lithuania, the Ministry of Social Affairs, also introduced the pilot project on supported decision-making. So first of all, a vision for the development of supported decision-making model was initiated by the ministry, very much discussing this with the NGOs and developing this description of service provision for support in making daily decisions. And then the pilot project was launched, which actually now empowers or applies for cases, for supported decision model cases run by a few NGOs that actually try and develop day by day those supported decision-making mechanisms and models in practice. So there is a good perspective of this pilot project, which should be continued by the national program for supported decision-making model, but again, there are some buts, because in practice, of course, there is no the universal standard for supported decision-making, and unfortunately, some of the NGOs or some of the service providers, they provide more paternalistic approach to support, and actually in general provide this substituted support or substituted decision making, but there are also very good practices for real empowerment of a group of people with indicated support needs. So again, the practice is, I would say, now evolving and developing, and we should very much look forward for improving this. So as mentioned, there are gaps and challenges of the reform, and since I was advocating for the much more higher perspectives and much more higher ambitions in this legal capacity reform. But looking at those gaps, I would say that, first of all, there were lack of awareness raising and capacity building for specialists dealing with this reform. So no proper trainings for judges, for social workers, for psychiatrists, in really changing this attitudes and approach from the legal incapacitation to the support for decision-making schemes. So it's really the lack of short of time for preparation of the reform, also lack of capacity building and lack of awareness raising, and little progress, unfortunately, in using alternatives, because we have only very few advanced directives being registered, and also very few agreements for support being registered in the registry, which shows that, again, those alternatives either are not known or cannot be effectively used in practice because of the still existing legal or administrative challenges and gaps. So despite the fact that it was the biggest reform of civil code, we failed really to comply totally with the CRPD, but there are now discussions, and actually the policy, also the government's measures being provided in the government's program, that in 2023 we should again come back and look for this legal incapacity institute to be totally maybe changed and to be more supported decision-making models developed in practice. So, and another practice that I wanted to share, the Lithuanian case that I wanted to share experience and practice with you, is that Quality Rights Initiative in Lithuania, which again was very much related, and I would say the active role of NGOs and advocates for human rights-based approach in mental health care was a key pusher or key roller in this Quality Rights Initiative in Lithuania. And those are some figures or some facts that I would like to mention, because we really moved very much towards the continuous and sustainable implementation of quality rights toolkit and initiative in Lithuania. So In 2016, Lithuania joined the WHO Regional Office of Europe project that I mentioned previously. So we were part of this project in respect that Lithuania agreed also to participate in this project and provided a lot of information, first of all, for the European region on people living in different kind of institutions, so statistical information, figures, and etc. That was phase 1 of the project. And then the expert team that also yesterday, today morning, Karile also introduced, we were selected as a national expert team. The team was established and trained and provided or carried out the assessment of 3 residential institutions in Lithuania. So those 3 institutions were part of the European-based project, which covered in total 96 institutions being assessed over the European region from 27 countries in total participating in this. But nevertheless, we as a national team, we provided, of course, the results, as I said, anonymous results only to fill into the international report. And then, fortunately, this kind of initiative didn't end it here, because with the support of the WHO Vilnius region, we kind of also managed to complete the intervention improvement phase for those 2 of the residential institutions that were being assessed. And those quality improvement interventions, it very much differed on the recommendations that we came up for, but usually it was very close work together with the facilities on the training of the staff, on the human rights approach, on the also improving some very daily practices to be more compliant with the well-being and human rights approach to persons with disabilities receiving the services. So this we managed to do, and then started the kind of long negotiations and discussions with different ministries, so the Ministry of Social Affairs and the Ministry of Healthcare, how to proceed afterwards. And those discussions were very relevant at the point that actually we as a national expert team, we were very much, I would say, pushing for continuation of the work to be done. And since 2021, another phase of implementation of Quality Rights Toolkit started, which I will leave actually to maybe to comment for my colleague from the Ministry of Healthcare, because I think this is a very crucial now point that we are in Lithuania with regards to the sustainable and continuous implementation of the Quality Rights Toolkit. From my point, concluding remarks and the way forward is very much related to couple of factors that actually are crucial for this quality rights initiative to be continuous. So first of all, political will and interest from the top, from the ministries, to really support this human rights approach and systematic approach to the mental health care services in general, based on the CRPD and international standards. Also, it should be very clear that the same attitudes, the same understanding of the CRPD values is very much seen both at the ministries level as well as the managing team level, to be on the same page and to understand that the standards are the ones that CRPD provides and that we should really follow those. Top-down approach is not necessarily the most effective, because we need to involve institutions themselves. So from the ground level, that we need to see the willingness from the institutions to cooperate and discuss it openly, because again, the communication risks are the ones that if the institutions will see this only from the point of view of assessment and that's it, or criticism and that's it, this will not really happen effectively. So the focus should be really on the improvement potentials, on the process to reach for the human rights based approach and quality services based on human rights standards. So, and also as I said, the long-term sustainability and goals for the future should be very clear, because again, we don't want to be only running the project from project, but it needs to be really very comprehensive and long-term perspectives. So with this, I'm very glad that Ignas Rubikas from the Ministry of Healthcare agreed to actually maybe discuss and say some few words about those prospectives and perspectives that Ministry of Healthcare and together with the Ministry of Social Care is foreseeing for the Quality Rights Initiative.
So thank you, Davila, very much for this elaborate and comprehensive presentation. This is my presentation wasn't planned in the program, so it will be kind of an improvisation. Hopefully, it will go fine. Yeah, so it will be very short. From the policy perspective, it is I would say a case study of Lithuania, how we start this thing and how we are made first steps forward, and how we will move forward to make it a systematic and routine practice to do quality right assessments in all kinds of mental health and social care institutions. So I am Ignas Rubikas, and I'm from the Ministry of Health, head of Mental Health Division. And why we are starting this and why we're starting this in inpatient wards in the beginning is because the mental health structure in Lithuania is still dominated by inpatient services. It is half of all specialized services are inpatient, and it consumes 2/3 of all mental health expenses. So it's probably not a unique situation, but it also motivates us to go and see what's there. It's also, closed institutions always have this higher risk of all kinds of human rights violations. So first, setting the scene, what do we have already in Lithuania before starting our actions? So first, the current government really puts a lot of focus on human rights, and this is a good thing, not only in mental health, in other areas, but obviously in healthcare. Mental health is one of the most sensitive areas where human rights is not only related to a moral case, but also a practical case. You cannot solve mental health problems without improving human rights aspects. So the government program and the government action plan both included very clear and strong commitments for assessing, evaluating, and then improving human rights situation in healthcare institutions. Then we had to choose the approach, and to be honest, there wasn't much of a discussion here, because WHO Quality Rights Assessment Toolkit is already a very comprehensive, high-quality framework that we are decided to use, and we have a lot of support from WHO and our national experts. So this was like an obvious choice to make. And then we, as Davila is one of the 4 experts, but we also have other experts who are really prominent human rights advocates in Lithuania who are trained and certified in doing these assessments. So that was also an obvious choice. Second thing is piloting the Quality Rights Initiative in Lithuania. So it started with last year. We did 2 mental health hospitals and some of those results were very encouraging. And this year we're also doing a more in-depth assessment of another mental health hospital with looking at different wards and different units in more detail. And what's important is that after the assessment, from the beginning, the principle was that it's not only assessment and we just leave the institutions with their own findings and problems and things to do, but we also provide consultations and continuous support by the same experts who did the evaluations. So this is very important to provide continuous support. Main conclusions from the piloting projects was that there are, thankfully, no dramatic human rights abuse, but of course there are a lot of areas of improvement, both nationally and of course at the institutional level. In addition, recommendations to institutions were provided, and in some hospitals, results are were also well publicized among the staff. So this already contributed to some extent to the culture change within the institution, so that it becomes a normal thing within that large, I would say, hospitals. Where we need clearly better effort and better collaboration partnership is in actually doing the hard part after the assessment, after the recommendations. How do we move forward with them? How do we change the culture? And of course, that's a complex and a systemic thing, but we have a plan for that as well. And then the third thing is what we are now moving forward, and we started the first steps, is scaling this to a national level with the ultimate goal of this becoming just a routine thing that no one actually questions about, no one raises an eyebrow about, just quality assessment as a routine process within mental health care institutions. So first we had to scale the capacity, and we had a training recently with the WHO Melita Murko and our national experts. We trained 12 really excellent new experts in quality rights assessment, and they are really happy about this. We're going to continue collaboration and start assessments early next year. Second thing is ensure access to knowledge, not developing, but translating and adapting all the methodological documents, online trainings, and so on. Then facilitating interest and inclusion. This is one of the more difficult and long-term aspects. As Dovile has mentioned, it shouldn't be a top-down approach. This is quite a challenge because, ministry is usually quite used to the model where it, gives some legislation, gives some rules, and then expects that everyone just implements that. This doesn't work in this way here. So we need to have a lot of discussions. We have to find first those pioneers, the early uptakers, and then from that place we have to, somehow work with the culture change and trying to convince more institutions to uptake that. So we're doing that. And then sharing experience with other countries. Probably this year could be called a breakthrough year for quality rights, because so many institutions in many countries and ministries have joined the common effort to expand and implement quality rights initiatives in their own countries. We met with some of them in Europe just to share our steps, experiences, and see what we can learn. I think that's very important. And then what we did, and we're very thankful for the Ministry of Social Affairs, that they also got involved in our effort. As Dovile said, this tool is really universal, not only for mental health care institutions, but also social care homes. We have a lot of them, and this is also not really, they also have similar problems. So beginning with the next year, we'll start evaluating both of them. This is also very important. And then the ultimate kind of structure for that will be given by a long-term design, which is a regulation that sets the principles, the processes, and the actions and responsibilities for who does what, in order to ensure that this becomes a routine process. So first, how do we work with how do we build up the interest, how do we evaluate, how do we follow up, and how then we monitor the results of those evaluations on national and on institutions level. So all of these actions are part of our policy implementation, and we are planning to at least gain momentum by the first half of the next year. As a matter of why we, as a country, really interested in quality rights, from my as a policymaker perspective, there are 3 reasons. So first is actually, what is quality in mental health? How do we measure the quality of the services? It's a question that's really doesn't have a clear answer, and there are many initiatives that try to do that. And this is one very valuable approach. Quality rights really tries to capture the concept of quality in a very particular but also important sense. So it also has practical tools. So for us, it's very important to evaluate quality in this sense. It's also very important because culture change is a very complex thing to do. One of the the key concepts here, of course, are recovery-based approach and human rights approach, but you need many doors how to enter to the minds and souls and hearts of the institutions, the administrations, the healthcare workers, and this is one of them. Of course, it's not the only one, but our goal is for everyone who works in the healthcare sector, wherever you go, you meet human rights approach and human rights tools, elements, and services. So you have nowhere to hide. So this is one of our strategies. So that's the reasons why we attempt to do this from the policymaking perspective, and perhaps the Lithuanian case is something that might be useful for others as well. Thank you.